Rosli, who is the Pediatric Registrar in the Department of Pediatrics. We also have Dr. Jenny Chan Lian, who is the Pediatric Specialist from the Department of Pediatrics, Hospital Pakar Kanak-Kanak UKM. We also have with us Dr. Tan Jan En, who is the Pediatric Neurologist from the Pediatric Department, HPKK UKM. And we also have Dr. Chai Jianing, who is the Pediatric Radiologist from the Department of Radiology, Faculty of Medicine, UKM. All right, so without further ado, I would like to invite Dr. Muhammad Safwan to present the case today.
Okay, Assalamualaikum and good morning. I will start with the case presentation. So here I have a baby of NS. It's a moderate preterm at 32 weeks plus 4 days with low birth weight of 1.53 kilo. And antenatally, mother NS is 39 years old, primary gravida. We're having an involuntary subfertility for total of 14 years. For this pregnancy, it was a spontaneous conception. And during antenatal follow-up, she was diagnosed with gestational diabetes mellitus, which was well controlled with the metformin, and her BSP also well optimized. And because of the advanced maternal age, as the mother is 39 years old, she did a DT scan at 22 weeks that showed multiple echogenic foci at bilateral cardiac ventricle. Other structure was normal. So she presented to hospital at 2 weeks plus 4 days with one history of reduced fetal movement. Otherwise, she denied any sign symptom of labor. There is no leaking, no fever. Because of the preterm, she was given a step dose of IM dexamethasone, and cardiotocography and CTG show variable deceleration, which is a pathological deceleration. Thus, she was posted for emergency lower segment cesarean section under general anesthesia. So moving on to birth history, baby was born not vigorous, limping, poor muscle tone, poor breathing effort with meconium stain liquor. She was intubated at 4 minutes of life in view of persistent bradycardia despite initial step and also 2 cycles of adequate positive pressure ventilation. Apgar score was given 1 at 1 minute of life, 6 at 5 minutes of life, and 7 at 10 minutes of life. Otherwise, her blood gas showed no acidosis. On physical examination, this baby was dysmorphic by evidence of temporal narrowing, prominence eye, U-shaped cleft palate, overlapping fingers with fixed plantar flexion. Upon handling, she only had minimal spontaneous movement. Other than that, there is neurological involvement, which there is hypotonia and hyporeflex of all 4 limbs. Other systemic examinations are unremarkable. For the anthropometric measurement, this baby was SG, small for gestational age, in view of all the weight, length, and also occipital frontal circumference was less than 9 centi. This by using the UK WHO chart 2009. So the progress at day 5 of life, while the baby was still intubated, she developed first episode of seizure. So subsequently, she developed another 2 episodes of recurrent chronic seizure at day 5, at day 8 and day 10 of life. So total there is 3 episodes of seizures. This is the first blood investigation for this baby. As we can see from the full blood count, the white cell count, the platelet all normal, but the HB is slightly on the low side, 12.5, where we expect the HB usually 40 to 50 in newborn. Other than that, all renal profile was normal, except the magnesium was low, 0.62, and the septic parameter, which involve procalcitonin, C-reactive protein, was low, not sensitive for infection, and the most important one is random blood sugar was also normal. So there is no hypoglycemic episode. So in summary, we have a baby of NS. We was born preterm at 32 weeks which not born not vigorous. She had recurrent episode of chronic focal seizure since day 5 of life. Clinically, she was dysmorphic with generalized hypotonia and also hyporeflexia. So I'm moving to my differential diagnosis. So the first one is hypoxic ischemic encephalopathy. Why I put this as my first differential diagnosis? The point for this diagnosis is the first one that is a sentinel event. As we know, the first CTG before went for seizure was show fetal bradycardia, and there is a mechanism stain lacqua, and the first APGAR at 1 minute of life also low, 1 only, and require positive pressure ventilation, and the APGAR improving after that. And there is also recurrent chronic seizure start at day 5 of life. The examination also show hypotonia and hyporeflexia. So points against this diagnosis was the first one is cord blood. The cord blood was normal, there is no acidosis. And the poor APGAR, one maybe due to maternal GA that caused respiratory depression. And the onset of seizure is late. Usually in hypoxic ischemic encephalopathy, the onset of seizure quite early at day 1, day 2 of life. For this baby, it happened at day 5 of life. And for this diagnosis, I need more further history and examination in terms of any placenta, any retroplacenta clot, any hypoplasia of the placenta, and for the cord, we need to know if there is any true knots, any hypercoiling of the cords. And I need to do more detail on examination by motor reflex. Is it complete or not? Sucking reflex, but for this baby, it is preterm, it's difficult. How about the pupil size? Is it unequal or dilated, or is this any exaggerated headlet? And another one for the vital sign, we need to see is any the trend of bradycardia. And for the further investigation, I would like to see any, as we know, the hypoxic ischemic encephalopathy usually is multi-organ involvement, to look for liver, any transaminitis or coagulopathy, any cardiac, is any myocarditis based on the cardiac enzyme. How about the muscle? How about the CK? Is it raised or not? Any adrenal involvement? Is it any adrenal hemorrhage or kidney? Is it any acute kidney injury? And for the FBC, I would like to look for immature nucleated red cell. As for the hypoxia, if there is evidence of hypoxia, there will increase erythropoiesis that lead to increased number of immature RBCs. And another one for the next one for the imaging. For the imaging, both either ultrasound cranial or also MRI brain, I would like to look for any cerebral edema, any white and gray matter differentiation, or any intraventricular hemorrhage. And at the same time, we can do also amplitude electroencephalogram, where we can see any, is it an abnormal background activity in terms of voltage, either it's normal voltage or continual low voltage, or any seizure activity. For my second differential diagnosis was infective cause, either it's meningitis or intrauterine infection. So the points for this diagnosis, the first one, again, the seizure since day 5 of life. And then there is a mechanism stain lacqua, and also the most important one is symmetrical, small for gestational age. But the points again is, for the first one is mother had no risk of sepsis. She just came with the residual fetal movement. There is no leaking lacqua, no chorioamnitis. And then on examination, for the intrauterine infection, there is no hepatosplenomegaly, there is no skin rash, anything. And for the meningitis, there is only hypotonia, hyporeflexia, where we expect is hyperreflexia, hypertonia. And the investigation that we done initially, the septic parameter was not raised. And for the further history for the mother, I would like to get any further history regarding the high vaginal swab. Any swab was taken throughout the pregnancy. Any history of group B streptococcus or streptococcus aggregate infection throughout the pregnancy. And for the uterine infection, especially for the torches, I need to ask regarding any pet or at home or history of raw or undercooked meat. And for the examination, we need to do the eye assessment to look for cataract or chorioretinitis. Fontanelle, is it bulging, is it tense for the meningitis? And later we may need to do the hearing assessment for sensory neural hearing loss. And for the investigation, the most important one is the blood culture. We can detect any organism, especially the GBS organism. And the next one, we need to proceed with the lumbar puncture. We need to rule out meningitis. From the lumbar puncture, we can see the cell count. How about the glucose ratio? How about the protein level? And the most common intrauterine infection was torches serology. So torches, because we have a lot of medical students, it stands for T toxoplasmosis, O for others, either syphilis, R for rubella, C for cytomegalovirus, and HES for herpes simplex. So the torture stand for. So the next one for the imaging, either ultrasound cranium or MRI brain, we want to look for any classification, especially for the periventricular, especially for the CMV infection or the toxoplasmosis, any ventriculomegaly, or other than that, any for MRI, we can look for any meningeal enhancements. So the third definition analysis was intraventricular hemorrhage. So the most important point for this diagnosis is the baby was preterm at 4 weeks. As we know, in premature, the brain structure and the vessel was very fragile. So the high risk for IV intraventricular hemorrhage. And another history, again, the seizure at disease day 5 of life. And the investigation that's towards this intraventricular hemorrhage was the HB. The HB, we start with low, 12.5 below the normal limit for newborn. But the points, again, this was against the delivery was smooth. There's no birth trauma. There is no instrumental delivery. And the baby also had no bleeding tendency. And from our full blood count also show there is no thrombocytopenia. But we need to get further history regarding any family history of bleeding tendency, such as hemophilia. And for examination, we need to look for any scalp swelling, any bleeding tendency, bruises all over the body. And further investigation, we need to send for coagulation profile to look for any coagulopathy. And the most important one is imaging. We can see intraventricular hemorrhage from the ultrasound that we can grade 1 to grade 4. So the next one, the fourth definition was metabolic abnormalities or inborn error of metabolism, or the short form is IEM. So again, this mother was diagnosed with gestational diabetes mellitus and got recurrent seizure at day 5 of life. So, and on examination, there is dysmorphic features, as we say before, and also hypotonia, also hyporeflexia. And the points for this metabolic abnormality was the magnesium was on the low side, 0.62 millimole per liter. That's the only positive finding for electrolyte. But the points, again, this one was the metabolic, there's no hypoglycemic episode throughout the pregnancy. There is no family history of all previous hepatitis child because the mother is the primate. And for the investigation, other electrolyte was normal, especially the calcium. As we know, the level of calcium in infant with the gestational diabetes always usually on the low side. And for the further history, we need to get the detail about is this a consanguineous marriage or not. As we know, in inborn error metabolism, the mode of inheritance mostly is autosomal recessive. Any family history of early neonatal death, cerebral palsy, or developmental delay, we need to get a 3-generation family history. And for the further investigation, for the IEM screening, we need to send for plasma amino acid, uric organic acid, and also dry blood spot acylcarnitine. And we need to see for the most ammonia and also lactate level, or we can see from the blood gas, is it any metabolic lactate acidosis. And for the MRI brain, we need to look for especially for the inborn error of metabolism, there's no specific finding, but we can see any diffuse generalized edema in urea cycle defect, any increased sign of melanated structure in maple steroid urine disease. And for the EEG, we can look for any spike wave or pattern of seizure. So the fifth definition analysis was the brain structure abnormality. So this baby, again, the history is premature at it's at 34 weeks. And the seizure also happened since day 5 of life. And then why the examination, this baby, we can suspect for brain structure abnormality because this patient was dysmorphic. So we suspect maybe he's having a central line defect, or central midline defect. But the points, again, this was the detailed scan done at 22 weeks, only show multiple echogenic foci rather than any brain abnormality. And for the history, we need to ask the mother any history of exposure to harmful substance such as alcohol that can lead to fetal alcoholic syndrome, or there is any illicit substance such as methamphetamine or morphine that can cause all the structural abnormality. And for the examination for skin lesion, we need to see any neurocutaneous stigmata. And again, for the imaging for brain structural abnormality, we can do either ultrasound cranium or MRI brain to look for any focal cortical dysplasia, we call malformation of cortical development, any holophosencephaly or lissencephaly, or another one is polymicroglia. And the last differentiation was genetic abnormalities. This one I focus more on towards the epilepsy, neonatal epilepsy syndrome. The first point towards this one from the history, the seizure occurred late at day 5 of life, and then on examination, there's dysmorphic. The child was dysmorphic. There's hypotonia and also hyporeflexia. And the point against this one was the history. Detailed scan only show multiple echogenic foci, and the mother had no history of miscarriage before, because this was the first pregnancy. And for the further history and examination, we need to ask the mother if the family history of epilepsy. And then for further investigation, the most important one of genetic study, I will start with just a normal blood karyotyping to look for any abnormal number of chromosomes in cell, and it's because this child also dysmorphic. And another one, this child also from the details can show multiple echogenic foci, which soft marker for the aneuploidy. And if there is no finding, we proceed with more detail, or we call it genomic technology. We can do the whole exome sequencing to look for any certain gene mutation that towards the neonatal epilepsy syndrome, such as a KCNQ2 or SCN2A. And then again, the most important one is we need to do for EEG to look for any showing diffuse slowing of the background or any frequent seizure discharge. Thank you.
Okay, thank you, Safwan. Going back to your list of differential diagnoses, I'm more interested in your 5th diagnosis of genetic syndrome, which is a very broad differential.
I mean this one, is it?
Yes.
Okay.
So you talked about neonatal epilepsy syndrome.
Yes.
Can you narrow down
So from the latest
your diagnosis?
International League of Epilepsy guideline, we have two. Either is self-limiting neonatal epilepsy, or another one we have early infantile developmental epilepsy encephalopathy. So there's two differential for this one. Okay,
so which one do you think?
Because so for this baby there's dysmorphic, and also there is a neurological finding which is hypotonia and also hyporeflexia. I more towards the second one, which is infantile developmental epileptic encephalopathy.
Okay, all right, thank you. Perhaps Dr. Jenny will be able to provide you with more information regarding the patient and some of the investigations that may help you with narrowing down your diagnosis.
Okay, good morning, everyone. I will continue with the presentation for the CPC to answer whatever Dr. Safwan would like to know for the further history, clinical science, and investigations. Okay, so for the history, Dr. Safwan would like to know these details. There are no pets at home, no consumption of raw or uncooked food, no exposure to harmful substances or alcoholic beverages or radiation during pregnancy. In this family, there are no family history of early neonatal death or epilepsy, no family history of bleeding tendency, no consanguinity. Antenatally, high vagina swab was not taken, so we could not elicit any history of GBS. Mother also has no febrile episode during this pregnancy. Placenta histopathological has been sent, and it showed retroplacenta hematoma. Placenta swab culture showed no growth after 48 hours. Umbilical cord was not sent for investigation. Okay. The further sign that in this case, this baby, besides hyporeflexia, hypotonia, Moro is incomplete. He has not developed any sucking reflex. No scalp swelling seen, no bruises seen. There are also no stigmata of neurocutaneous stigmata. Heart rate has been normal since birth, around 140 to 150 beats per minute. On day 5 itself, ophthalmological team come in and assess, so eye examination is normal. Further investigation required. Dr. Safwan is asking about the nucleated red blood cells from the full blood count. It is 6.3%. Okay. We have the results for liver function tests and to look for other organ involvement in hypoxic ischemic encephalopathy like CK, cardiac troponin I, coagulation profile, lactate and ammonia, which Dr. Safwan will help us to interpret in a while. IEM screening show normal amino acid and SR carnitine profile and normal organic acid profile. Baby torches for all IgM and IgG are negative, whereas for mother's torches, toxoplasma IgG, cytomegalovirus IgG, herpes simplex 1 and 2 IgG are positive, whereas all the IgM serology are negative. We also send for urine PCR for CMV, placenta CMV, immunohistochemistry, which all come back to be negative. And because of the imaging finding, which Dr. Chai will reveal later, we also send off urine PCR for Zika, which is negative. This baby is dysmorphic. We send off the initial karyotyping, which come back to be normal. Okay. Lumbar puncture done also. And we have the result for the biochemistry, FEME, and CNS as well. Okay, so with this, maybe we can invite Dr. Safwan to further enlighten us to narrow down the differential diagnosis.
Okay, so we go through the first one is I can say for my first definition was hypoxic ischemic encephalopathy. So there is a retroplacental clot. So we can see the sentinel event that points towards our diagnosis, and also from the we can see liver function test. We can see the AST slight on the high side. Other than the ALT is normal. CK was normal, but the most prominent one is cardiac troponin I is raised. So maybe there's some involvement of the cardiac. Other than that, the coagulation profile, the PT for the preterm slightly raised, maybe some element of coagulopathy. And then lactate also raised. Ammonia raised on the high side because the normal level about 60 to 70. But the IN screening was all normal. So we can roll out the first one here. For the first one, for hypoxic ischemic encephalopathy, we still can't roll out. But for the infection, for the torches, baby torches was negative despite the mother cyto CMV, toxoplasma, and also the herpes simplex was positive, it's IgG. And then meningitis. Now we able to rule out the meningitis because the first one, the cell count is nil, and then the glucose ratio also not suggestive, significant if different more than 60%, and then the protein is normal despite race because in preterm there is immature blood-brain barrier, so that's why the protein is high, but still normal for the newborn. And the culture and sensitivity all no growth after 48 hours. So now we can roll out the infective cause based on the septic parameter not suggestive, the LP also not suggestive. And then for the next one, we can roll out also the torches infection. And for the inborn error of metabolism, just the amino lactate on the high side, but the normal, the basic simple 3 test is still normal. And then, but we still able to roll out here from the on investigation, is it the intravesical hemorrhage? We need to do the ultrasound or MRI. And the most important next one is the imaging. I think that's it.
Okay. Based on the investigations that we have given you, yes. Do you still think hypoxic ischemic encephalopathy is? Would you still consider HIE as one of your differential?
I still consider because the first one there is a retroplacental clot, and another one from the there's multi-organ involvement in terms of liver. It's a coagulopathy, and the cardiac troponin I also raised So there is a cardiac involvement. Still unable to rule out the hypoxic ischemic encephalopathy.
All right. Any of your differentials that you can probably put aside at this point based on the investigations that we have given you?
So for the time being, hypoxic ischemic encephalopathy, and then we still can't rule out. Another one is structural abnormalities, and another one is genetic cause. That's the only thing.
All right. So what about the inborn error of metabolism?
Yes, there is ammonia and lactate abnormal slightly risk, but the basic IM screening was normal, which involved plasma amino acid, urine organic acid, and also dry blood spot.
So do you still think it's possible to be one of the IEMs?
I don't think so.
Right. Okay. Maybe we can invite Dr. Chai to enlighten us on the radiological findings.
Hi, good morning all. I'm Dr. Chai, radiology. So I heard Safwan is calling for imaging. So we have done the ultrasound brain for this patient at 5 days of life. And this is how the ultrasound look like. This is a bedside scan. And on the top row is your coronal view. Okay. And we have this label here this is the right hand side of the patient. This is the left hand side of the patient. So from this coronal view, you can see that actually there's reduced sulcation of the brain surface. That is one thing. And the other thing that is we saw all this hyper echogenic focus in the white matter region of the patient brain. It's bilaterally, and they are bilateral but slightly asymmetrical in distribution. Okay, which all these are suggestive of calcification. In terms of the ventricles, we do not see any obvious ventricular hemorrhage, and you can see that this is a normal choroid plexus, and the ventricles are not dilated, and we have this frontal horn bilaterally, so there is no hydrocephalus as well. So on the sagittal view, not much we can show, but it's again that the hypoechoic foci, which represent the calcification that is seen in the white matter of this patient bilaterally. This is on the right side, right parasagittal view. And this is the left parasagittal view, and you can also see the hyperechogenic foci. So from this ultrasound, there is a lot, we can conclude that this patient have brain calcification with probably pachygyria because of the reduced gyration, but the MRI will show us more. So the MRI is being performed on the day 21st of life. So these two sequence over your left, this side is the Siew sequence. It's good to pick up all the calcification and also hemorrhages. And also on the other side, the right-hand side, is the phase sequence, which give us information whether it is more likely to be a calcification or is hemorrhage. It's not very straightforward in MRI to differentiate these two. So from what we have here, this is the axial images, and you can see that there are some blooming artifacts. So this hypo-intense signals lesion, punctate lesion, these are what we call blooming artifact on the Siew images. Okay, you can see it is happened at bilateral cerebral. But because the patient has an abnormal sulcation, and later on in the T2 image, you will see that actually this punctate blooming artifact, they are at the gray and white matter junction. And it also, this is at a higher cut. You can see how the blooming artifact here. And why do I need to put on the phase sequence? Is that I just want to show you that how the signal is being suppressed. Okay, similar to your brain, to your skull. So this means that it is calcification rather than hemorrhage. So this patient have bilateral cerebral hemorrhage. These are the T2 sequences, and it's very good to look at the gray and white matter characteristic. This is on the axial view, and this is another axial cut, and we have a coronal view images. And you can see that there is reduced sulcation of the brain. right? And the sylvian fissure is rather smooth. There's not much of operculum that develop around here. And we have a lot of this small, lumpy, and also bumpy surface of the brain involving both sides. It's not very clear, but that is the reality. This is what I have. Okay, so it means that this patient actually has polymicrogyria because of all these small lumpy structures that we think is more of polymicrogyria rather than pachygyria. But in fact, that it still have a reduced sulcation as well, which is actually quite extensive, not just at the bifrontal region. You can see at the right side, right occipital lobe also same, and then there is also blurring of gray-white matter differentiation at the temporal region. So it's actually quite extensive. This patient does have malformation of cortical development with brain calcification. This is the mid-sagittal view. Just want to show you that the corpus callosum of the patient is complete but is thin out. And at the lower cut, we are looking at the cerebellum here at the axial view. So you can see multiple blooming artifact, which this time around is more obvious. But in the phase sequence, there is no signal suppression like what we saw just now at the supratentorium. So this bilateral blooming artifact in the cerebellum are more suggestive of cerebellar hemorrhage. And on the T1 weighted image, you can actually see a subtle hyperintensity signal that corresponded to the area of blooming artifact. So these are the causes of intracranial calcification by A. So if we found the intracranial calcification at birth or very near to birth, then the differential diagnosis is usually fall within this list. And you can note that in this list, there is actually a lot of congenital infection. All right, a lot of torches is on top of it, like almost all the members of it, even the pseudo one also in it. All right. So, but later on, in the later life, the brain calcification have other differential diagnosis. So now we can focus on here. In terms of the location of the calcification, because the calcification located at the subcortical, meaning that it is at the gray-white matter junction, so it's just at the subcortical region. So there is a long list of differential diagnosis that can have calcification, brain calcification at the subcortical region. But among all these, who can have cortical malformation or cortical development? So only these few have associated malformation of cortical development. First one is CMV, and then the second one is Zika, and the rest are pseudo-TORCH, and also the lastly is a genetic mutation of SCN3. So I have put it up just for the learning purposes, and you can see that the congenital CMV is actually quite frequently seen. All right, so it has variable types of intracranial calcification. So subcortical calcification is one of it, but most often it happens at the periventricular region, which is not seen in this patient. All right, and then this congenital CMV can cause a lot of malformation of cortical development. So same goes to the Zika virus. Zika virus can also cause malformation of cortical development, but Zika virus calcification is typically at the gray-white matter junction, which is at the subcortical region. All right, as you can see here. But what is lack of in this patient is that there is no severe microcephaly in this patient. So it's kind of against Zika a little bit, but the location of the calcification could suggest a Zika. And then the rest is torches, pseudo-torch 1, pseudo-torch 2, which are very rare, but these two, they usually have associated with cerebellar hypoplasia, which is not seen in this patient. And then lastly is the SCN3A. They said the classical kind of appearance of the calcification is usually flame shape, but ours calcification is more of punctate calcification. So in conclusion, this patient, I think what we need to focus is that it has brain calcification, this neonate, and also it has malformation of cortical development. By combination of these two, these are the shortlisted differential diagnosis from the imaging mice. Okay, I know we have done a lot of lab tests and some of it has been excluded. but for the cerebellar hemorrhages, it's not being described in any of the differential diagnosis, and it could be due to the prematurity and also the stomy birth history of this patient. That's my opinion. Okay.
Okay, thank you, Dr. Chai. Can I invite questions from the audience, if there are any? No questions. All right, okay. Perhaps we can invite Dr. Safwan back up. Maybe you can, with the help of the imaging, now narrow your differentials even further.
So thank you, Dr. Chai. So after the imaging done, so from the first ultrasound, we just got the classification. So there's a brain classification, which most likely towards the torches, but our torches, especially the CMV, but our torches is negative. At the same time, we have a cortical brain malformation, as she says. So now we have two differential diagnosis, either the cortical brain malformation or genetic, based on the possible SCN3A. That for now.
Okay, so based on the imaging findings and the other investigations, how would you proceed?
I think the next one we should go towards the genetic study, which is we can do the genomic sequence. It's an example is a whole exome sequence, WES.
How would that help you?
So because from the imaging, one of the differential analysis of the SCN3A, one of the genes, maybe we can detect from the WES specifically for that gene.
Right. Would you consider your pseudotorch now as one of your differential?
I'm not sure about the pseudotorch.
Right. Okay. Dr. Jenny, maybe you can help Dr. Safwan.
Okay, so I think at this point, with the help of the imaging, both ultrasound and MRI, Dr. Chai has already helped us to narrow down most of the diagnosis. I'm just here to update everyone on the progress and also our final diagnosis. Okay, so so baby of NS continue to have refractory seizures in NICU, loaded, maintained with multiple anti-epileptic under neuromedical team, given IV levetiracetam, phenobarb, phenytoin, and as well as midazolam. Okay, she continued to have multiple breakthrough seizures even after discharge, and has marked developmental delay under physiotherapy, occupational therapy, speech therapy, and dietitian follow-up as well. Electroencephalogram has been done, which shows
Dr. Jenny, can you change it into a slide? Yeah.
Okay. Which show 4 episodes of seizures with 2 different simulology were recorded during sleep. So whole exome sequencing has been sent, and the result is SCN3A gene mutation. Our final diagnosis is developmental and epileptic encephalopathy SCN3A gene mutation. Okay, genetic team has counseled the parents of the prognostication of the child, and this disease be life-limiting. An advanced care plan was discussed with parents. So perhaps at this point of time, Dr. Tan can help us to explain a little bit further about what is developmental and epileptic encephalopathy.
Okay, good morning, everyone. So first of all, I would like to thank to the organizing committee for having me here today. So I was tasked to explain this concept of the developmental and epileptic encephalopathy. It's complex, but I will try my best and explain it with a step-by-step approach. Okay, so before that, we need to understand the definition of neonatal seizures. So traditionally, we classify it as clinical only seizures, electrographic only, or electroclinical seizures. But in 2021, the International League Against Epilepsy has defined it as an electrographic event with a specific characteristic, meaning that now we only have electrographic only seizures or electroclinical seizures. Why is it so? Because it was supported by very strong evidence. Eventually, even you are suspicious of a patient having seizures or there's an ongoing clinical event, you need a conventional EEG or even an amplitude integrated EEG for confirmation because the evidence is 1 and 2A. We can't diagnose it clinically because of the immature pathway of the term on preterm neonates, which I think a lot of movement may be non-epileptic in nature but misdiagnosed as an epileptic movement. So moving forwards, once you have diagnosed this is a neonatal seizures, so you can further classify it into the acute provoked seizures or a neonatal epilepsy syndromes. So the acute provoked seizures previously also termed as your acute symptomatic seizures, meaning that it was a one-off seizures. There's usually a cause, is either the meningitis or intracranial hemorrhage or even your electrolyte imbalance such as your hypoglycemia or hypocalcemia. While the neonatal epilepsy syndrome is a confirmed epilepsy. So for today, we will only focus on these neonatal epilepsy syndromes. Okay, how do we define it? First of all these syndromes, they must have a characteristics. So the common characteristic will be the seizure onset before 2 years old. They have clinical electroclinical phenotypes, and they are often supported by a specific etiology, and they have precision or gene-related therapies. Okay, so one of the common example will be your infantile spasm syndromes. The onset is usually before 1 year old, and the patients usually present with a clinical flexor or extensor spasms with a EEG findings of hips arrhythmia. So your TSC complex is one of the commonest cause for this infantile spasm syndrome, and the specific treatment will be your corticosteroid or vigabatrin. Okay, so moving forward, so now we have diagnosed a neonatal epilepsy syndrome. So it can further categorize into the cell-limited epilepsy and also developmental epileptic encephalopathy. Okay, so for that, to understand this better, they have a specific definition and characteristic that you need to know of. Okay, so self-limited epilepsy, I think previously we known it as benign epilepsy or benign infantile epilepsies. So the natures are they are likely to be spontaneous remission. So even with or without treatment, as you grow, they will outgrow it. And with treatment, they are very pharmacoresponsive. So it's just a low-dose anti-seizure medications. Most of the time, you can control the seizures very well. The patients might have normal or near mild cognitive impairments. Whereas in your developmental and epileptic encephalopathy, they usually have this epilepsy and neurodevelopment comorbidity, and they are attributed to both underlying cause and uncontrolled epileptic activities, meaning that whether the epilepsy is controlled or not well controlled, the patients are very likely to have this moderate or marked cognitive impairment due to the underlying cause. It might be a structural brain abnormalities or it might be a genetic abnormalities. And a lot of time, they are pharmacoresistant. Okay, so these are some of the examples of epilepsy syndromes. So in the self-limited epilepsy category, you can divide it into self-limited neonatal epilepsies. If you get it later on, you group it as a self-limited infantile epilepsies. And some of them, they may progress. They started early and progress to the febrile seizure blast, or the common one that we saw in the neonatal age is the myoclonic epilepsy in infancy. So we know these groups, most of them, they are going to outgrow it, except the febrile seizure plus. Whereas in the category of this developmental and epileptic encephalopathy, we have a few categories. So the common one will be your early infantile developmental epileptic encephalopathy and your infantile spasm syndromes. Okay, Dravet syndrome is under this group because the onset is before 2 years old, although they progress later on. Okay, again, after reaching the diagnosis of whether it's one of the self-limiting epilepsy syndrome or DEE, we do not stop that because we need to identify the etiology. So nowadays we will put on the etiologies on top of the diagnosis. So one of the example will be, I think, common gene that causing epilepsy syndrome will be your KCNQ2 gene mutations. So this KCNQ2 gene mutation depends on the variance of mutation. It may give you a self-limiting epilepsy or DEE. So if the phenotype is a self-limiting epilepsy, then you will name it as a KCNQ2 self-limited epilepsy. But if it causes DEE, then it will be a KCNQ2 DEE. So we have a quick look at our case. So this is a confirmed case of SCN3A DEE. So if you look at the workup, so first of all, the patients present with the sequential seizures. Sequential seizures meaning that they have a few types of seizures lying up in a sequence. For example, in this case, the baby started off with a behavior arrest, followed by focal tonic-clonic seizures, then followed by autonomic seizures. So we call it a sequential seizures. So when you have these sequential seizures, very likely you are having epilepsy, not acute provoked seizures. So next, with the EEG helps, so you found the findings of burst suppressions. So it kind of confirmed this patient is very likely to have epilepsy syndromes. So with more treatments, so you find the patients to have drug resistance with EEG manifestation. So you can define it as a developmental epileptic encephalopathy. So next, now we have MRI findings of a significant brain malformations. So is it sufficient to explain that this is the cause of DEE? Usually not, because with your brain malformation also they have a typical types of seizures. For example, your cortical dysplasia, they will give you a focal tonic-clonic seizures. If you listen carefully, they will give you infantile spasms. Very rarely they will give you a sequential seizures. So when you have a sequential seizures, you should suspect it's a genetic cause. So that's why I think in this case, they proceed with a whole exon sequencing, and finally we got the SCN3A mutations found. So the complete diagnosis will be a SCN3A developmental epileptic encephalopathy. So that's how we work out. Okay, so I hope all of you understand the concept of the developmental epileptic encephalopathy, or you are more confused, or now you'll become encephalopathy. Okay, that's all. Thank you.
Okay. Thank you, Dr. Tan. Any questions from the floor? Okay.
Just a couple of questions. What I noticed there's no discussion of EEG during the workup. Was EEG done at all, and how would that have helped if it's done early or if done much later on? Dr. Tan?
It will be good if we have a EEG done earlier, because I think that recognizing the findings, especially in this case, the burst suppressions, will aid us to narrow down the diagnosis even earlier.
So let's say now in neonatology we have AEEG, that's the amplitude EEG. Would that be able to help you, or do we need a full channel?
We will not need a full channel because AEEG can't diagnose burst suppressions.
Yeah. Well, it can, right? But it can't see the waveforms that you want to.
It can't be seen very well. We still need a conventional EEG to see the proper burst suppression form.
Yeah. I think if it's a global problem, the AEG will be able to detect the burst suppression. For example, in HIE. But I think because this is a focal seizure, it may not be able to detect the burst suppression.
Yeah, that's I agree with that too, because normally we see burst suppression in HIE, but probably you need to know some specific waveforms, right, in your condition. So is there a reason why we did need an EEG, or that was not discussed in the case? I just want to know.
I guess I think because to do a full in a HCTM, I think we don't have a proper full channel EEG.
Okay, so that was a limitation.
Yeah, that's a
limitation. Probably would have asked for an EEG if there is a readily available facility. Yeah, because look at the investigations, we were missing out on discussion of EEG. The other question is, so why is pseudo torch, Dr. Tan? What is pseudo about it?
Okay, pseudo torch is one of the syndromes that.
Sorry, no, Dr. Tan Jen, not Tan.
Okay, so in short, it's also a torch mimics. So I think nowadays they have recognized some of the syndrome with intracranial calcifications, and turned out the findings looks like a torch, but they were not. So one of the example they have actually named it is the icardicoidal syndrome. So nowadays there are more recognized syndromes belongs to these groups.
So the point to highlight here is intracranial calcifications traditionally thought to be torch is now not just torch, but it could be this
one of the genetics syndromes
associated with malformation of the brain, right?
Yeah, yes, correct.
Malformation. And the last question is, so what is SCN mutation? So what is this?
SCN mutation is one of the sodium channel mutations that can cause the epilepsy syndromes, but it's not one of the common genes. The common one will still be your SCN1A, 2A, 8A, and your KCNQ2.
So it's a channelopathy.
Channelopathy, yeah.
And because it's a channelopathy, it disturbs the neuronal impulses, right?
Yes, correct.
Yeah, just to
and this is one of the rare mutation that cause brain malformation together with the epileptic encephalopathy.
Okay, thank you.
Right, okay, thank you. I think Prof. Marina has got a question.
I'm from Marina from ENT ORL. Very interesting case. I would say that I follow, it is like a CSI for me. At the end of it, I'm the guy in the chair, encephalopathic. So I'm going to ask very basic question. First question is Dr. Tan here, radiologist. You perform, sorry, Dr. Chan, sorry. Sorry. You perform ultrasound brain, and then MRI. So my question is, would you not straight away do MRI? What is the advantage of doing ultrasound first and then you go for MRI? That's my first question. My second question is, I'm not sure who can answer this, maybe our ONG colleague here, if there are any. The detailed scan shows normal. So what is the chance that the detailed scan missed all these abnormalities in the brain during the antenatal ultrasound? Thanks.
I would answer the first question first. Okay. The reason we do ultrasound first is ultrasound is more available. We can even do it at bedside. So it depends on whether the patient was stable at that time. The MRI will need quite a long time in the MRI gantry. And we know that the MRI itself is a very big magnet, and there is a lot of monitoring, which is quite difficult. It's quite challenging. Okay, and the other thing is we have two hospitals, right? So HCTM only have 2 MRI. Okay, the MRI list is forever long. So that is also one of the limitations. So I think during management time, the bedside ultrasound would help just to pick up things that eventually will direct the clinician on how urgent the MRI should be and something like that. So that's why we didn't proceed with the MRI first. If the MRI machine is a very mini one or everyone also have one, then I think I will go for MRI. Who wants to do ultrasound? But that's not the case. So in pediatric, the brain is small and the ultrasound beam can penetrate. We actually have quite a good image of ultrasound, right? It's just that we can't really see the entire overview of it that much. So there's still very relevant even up to now that the ultrasound cranium is being performed. Okay, I think the next question is not for me, right?
Yeah, I think the other reason why we did the ultrasound first was because the baby was still quite preterm at birth and he was ventilated. So having an MRI done at that point was logistically quite difficult. Not impossible, but quite difficult for us to arrange. But I think subsequently we did the MRI at 3 weeks. Your next question was the antenatal findings. I'm not an obstetrician, but I don't know. I don't think there are any obstetric colleagues out here. But I think the detailed scan was done at 20. The scan was done at 22 weeks, which is pretty early to be able to see pachygyria and all the other structural or cortical malformations. Gross malformations, I think, can be picked up at 22 weeks. I am not sure about the subsequent scans, whether it was done or not, but again, it's not easy to pick up fine or very minute abnormalities from antenatal scans.
You are saying that the MRI findings here is considered small, minute for the detailed scan to be picked up.
It's not small, but it's not gross abnormalities. It's not like a cardiac defect or holoprosencephaly that can be detected antenatally, or an absent corpus callosum or gross ventriculomegaly. So these are cortical dysplasias which isn't easy in a preterm brain because their brain is still developing. So even pachygyria at 22 weeks, their brain is quite smooth. So it's very difficult to even pick up pachygyria at 22 weeks. So I think in the interest of time, we've got something special prepared for the medical students because it's related to your Kahoot later on, yeah? So please focus. All right, so Dr. Jenny.
I think the ultrasound is still very, very important at the bedside, and it helps us to pick up the calcification, Dr. Chai, and also very importantly to rule out intraventricular hemorrhage. And this bedside test ultrasound, I still want to say that we do need to do it because it's the best modality bedside to show calcification and hemorrhage, and that is necessary in this case.
Okay, I will just go through briefly. Actually, time is out already. This is for the benefit of the medical student. I'll just bring you all through the brief approach to neonatal seizures. Probably at this time, 50% of us are confused, 50% of us are encephalopathic. So I just go back to the very basic of our approach to neonatal seizures. Okay, just a very fast one. Okay, neonatal seizures is actually the most common neurological emergencies in neonates, and it presented in 1 to 5 cases per 1,000 live births. The definition of seizures is the same as any other children. It's sudden paroxysmal abnormal alteration of electrographic activities. But the clinical diagnosis is very difficult, particularly in a very ill neonates, because of the immature state of the motor pathway. So we have to recognize it and evaluate it to identify and treat the underlying etiology to prevent further brain injury and to stop the seizure activity. Dr. Tan bring us through the etiology just now, Actually, majority of neonatal seizure are acute provoked seizure. So 85% are acute provoked seizure, means that it is provoked by an acute illness or brain insult with an underlying etiology. Okay, so those differential diagnoses listed out just now: neonatal encephalopathy, structural brain injuries, metabolic, central nervous system or systemic infections, inborn error metabolism are all under this group of acute provoked seizures. However, there are also about 15% neonatal seizure. They are actually the first manifestation of early infantile epilepsy. Okay. So this is classification of neonatal seizure. Is a diagnostic framework of seizures in neonatal period, including the classification based on International League Against Epilepsy. So when a newborn comes to us with a paroxysmal clinical event suspected to be seizures of epileptical origin, whether it is motor or non-motor, most of the time, as Dr. Tan said, even exclusively, it can be just electrographic only seizures. So when we approach to the differential diagnosis, it's very different from our approach to older children or adults, where our first approach is to categorize, is this a focal seizure or generalized seizure? In neonates, we don't do that because seizures in neonates are exclusively focal in nature. Okay, so there is no generalized. Then the second step, usually in our approach to epilepsy in children, is whether this is impaired awareness or it is with awareness. Again, this is not possible in neonates because it is not possible for us to assess the awareness or responsiveness of neonates at this age. So the initial stage of our description of seizure is actually whether the seizure is electroclinical or it is electrographic only. In fact, a large majority of seizure in neonates are electrographic. Depends on the etiology. For example, in a hypoxic ischemic encephalopathy, 50 to 80% of the seizures, they are actually subtle. There are no clinical manifestation. But if we put on the air EEG, we can see the electrographic changes. So these groups are the electrographic only seizures. When they come to us with electroclinical seizures, that means they have the clinical manifestation. Then we will classify them. Either this is a motor or non-motor. Okay, so under the motor group of seizures, we have the automatism, the clonic, the epileptic spasm, myoclonic, tonic. So in all this, we can always classify whether this is focal, this is multifocal, there are symmetrical, asymmetrical, unilateral, bilateral. Okay, so all these are under the classification. But the point to convey to everyone is that, first of all, our approach to our classification of neonatal seizure is all entirely different from our approach to those in older children and adults. First step, whether this is electroclinical or electrographic, then only then we classify them according to the seizure type, whether this is motor, non-motor, and as in our case, is a sequential. Okay. Okay. Then, so for the medical student sec, okay, this is the important part. Just pay attention to the first tier test. So when the neonate come to us with suspicious of seizures or clinical manifested seizures, okay, the most important thing is to take a thorough history, do a full physical examination, including a full neurological examination. So as Dr. Safwan has bring us through in his history, we go through maternal history to identify any genetic or underlying acquired condition, any previous miscarriages, the underlying health problems like diabetes mellitus, whether the mother has any infections, any prenatal exposure to any illicit drug use, etc. Okay, then in the birth history itself, is there any risk of anosmic brain injury, any risk of intracranial hemorrhage? Then we do a full neurological examination, looking at the appearance of the child, whether the child is dysmorphic, okay, examine the fontanelles, go through the full neurological examination and systemic examination. Then based on the history and physical examination, then we'll proceed on with the blood investigation. So because electrolytes abnormalities are easily corrected, so we have to pay attention to any electrolytes abnormalities. The important ones: sodium, glucose, calcium, magnesium. Okay, all these abnormalities can cause seizures in children, in neonates. Okay, then proceed with liver function tests, ammonia lactate to look up for any possibility of inborn error metabolism, arterial blood gas, torches to rule out any intrauterine infections. Okay, we also do urine for toxicology screening and urine culture, and CSF to look for any signs of meningitis, and of course the neuroimaging such as ultrasound and MRI. Okay, so then we'll go through. So once we diagnose a child with seizure, the important thing is to stop the seizure. So neonate with new onset seizure, preferably confirmed by EEG, correct the reversible metabolic abnormality if present. Okay, if seizure resolved, for example, in this child initially has hypomagnesemia, after we corrected, it was normalized. So if seizure abode after that, then there is no need of anti-seizure medication. But if seizure present, start the first line of anti-seizure medication. So the first line of anti-seizure medication is always phenobut for most etiologies, whether it's hypoxic ischemic, stroke, intracranial hemorrhage, or CNS infection. But if there are any family history of channelopathy, then perhaps you should consider phenytoin or carbamazepine. Okay. If seizures continue after the first line of anti-seizure medication, then we can continue on choosing the second line of anti-seizure medications such as phenytoin, levetiracetam for those especially with cardiac disorder, or even the pyridoxine trial. Okay. Okay, so if seizure resolve, then we'll see whether these seizures are solely due to acute provoked cause. And if it is, then we can stop the anti-seizure medication after 72 hours of seizure-free before discharge and closely follow up the child. If not, we have to consider, is this a neonatal onset epilepsy syndrome and the need for ongoing anti-seizure medication therapy. If seizure continue, then we try other different second line of anti-seizure medication and refer to epilepsy specialists for management. Okay. Yeah. Okay.
All right. Okay. Thank you, Dr. Jenny. Right. So that will be the end of our CPC session. I hope everybody has learned something. All right. Okay. All right. So thank you everyone for attending the CPC today and for staying as long as you can and for listening, yeah, medical student. Okay, and you have got your Kahoot thing after this, yeah? Don't go back yet.